tumor as well. So there are a lot of people providing the care, and again, traditionally we haven't been working together. So when we look historically, what happened? Well, first off, the patient would go see their regular doctor, their primary care doctor with a spine problem. If the problem was simple, you know, an acute back spasm, the primary care physician will treat them. And if it's not simple, well, they'll refer to this amorphous entity of spine surgery. Well, it could be orthopedic surgery, it could be neurosurgery. And what happens is we see the patient, and more than 80 or 85% of the time we see the patient and we go, you know what, this is a non-operative problem. Only 10 to 15% of people are operative candidates. So that means that 80 to 90, 85, 90% of the patients that we see didn't need to see us. And that wastes our time, and that actually wastes the patient's time as well. They've waited for an appointment to see you for you to say, you don't need me. And also, the division between orthopedic and neurosurgery has been a long-standing thing. It's a function of local culture and bias. But if you think about it, how are we different? How are orthopedic surgeons and neurospines different? You know, historically, at least in North America, the paradigm was that decompression was done by neurosurgeons, so they were treating leg and arm pain, and stabilization or fusion surgery was done by orthopedic surgeons, they were treating back and neck pain. But in this era, realistically, our training is equivalent. Our institution, we have both orthopedic surgery trained and neurosurgery trained fellows, and there isn't a lot of difference between them. Although there are areas where we don't overlap, I do not do intradural tumors. The reality is the majority of spine pathology, the surgical part of it, can be handled by either an orthopedic surgeon or a neurosurgeon. And when we look at why we haven't cooperated, a lot of it has to do with turf battles. This is my territory, don't you step here. And finances. Where does the money flow? So what is the reality, though? I have way more in common with my neurosurgery spine partners than I do with my orthopedic colleagues where I work. 90% or more would do just as well with either an orthopedic surgeon or a neurosurgeon doing, but our main gap in these patients is who is providing and how are we providing the non-operative care to the 85% of patients who get referred to us. So why is this where we are? What's the status quo? Well, a lot of it is entrenched practice patterns and culture. This is the way we've always done it. Why should we change? As with most things, the money. Where does the money go? Surgery makes money. You ask any department chair, an orthopedic department chair, if he wants to let his spine program go. No, he doesn't, because the spine program pays for some of the programs that don't pay quite so well. We really don't have central coordination of patient referrals. The patients go, oh, I need to see a spine surgeon. Well, my neighbor up the street saw Dr. Zalelli. Dr. Zalelli was great, so I need to see Dr. Zalelli. That's where actually a lot of it comes from. And the other thing that happens, and the reason why so many of these patients get referred straight to spine surgery, is the primary care physicians are worried they're going to miss something serious. This patient is going to have a permanent neurologic deficit. I have to send them to spine surgery. Well, you don't most of the time. So what would an ideal system look like if we could provide the optimal way of providing care for our patients? Well, ideally, patients with an operative problem would quickly get referred to the appropriate surgeon. Patients with a non-surgical problem would not see a surgeon because they don't need that expertise. And the idea that the patient sees the right provider on their first visit. And errors will be made, but it would be nice if they came there that day, traveled however far to get to see us, and found out, oh, you're not a surgical candidate. Well, I can get you an appointment with our non-surgical guy in 2 months. No, if the non-surgical guy is right there and you can go, you know what, I'm just going to have my partner come in and talk to you. So how do you do it? And this is sort of what we learned at my institution and how we came up with this. So first off, we have to have a screening method. We have to have some way of deciding, is this patient surgical or non-surgical? And if it's surgical, refer it to the surgeon. If it's non-operative, refer it to that. If they need further workup, before you can make that decision, if they need other testing, you can then do the testing and then decide, does it go to the surgeon or the non-surgeon? And as I say, if an error is made in where they're supposed to go, you should have an immediate appointment with the available provider. So look at other models for providing multidisciplinary care, and probably the best example of this in many aspects is cardiac surgery and cardiology. The cardiac surgeon basically just is a technician most of the time. They see the patient just before the surgery, they explain what the surgery is going to be, and most of the follow-up care is actually done by the cardiologist. So that's a very efficient use of an expensive resource. Cardiac surgeons spend their time doing cardiac surgery. They don't spend their time doing cardiology. That doesn't make sense. But if you look at other models that are out there, some not so good, specialty warfare, where the neurosurgeons and the orthopedic surgeons are arguing constantly over who gets to do the spine or who does it. Other things that are out there, some of the institutions talk about having a virtual spine center. So they pretend to work together and they do some stuff together, but really it's still the same old silos. Then there's co-located silos. So that we actually have an outpatient clinic where the orthopedic surgeon and the neurosurgeon are both there at the same time, and the PM&R guy are both there at the same time, but they're still not working together. And then what I like to start thinking about is then we start looking at cooperation across independent disciplines. So you're actually working with your colleagues in the alternative fields. And then finally, a truly integrated multidisciplinary group. So when I look at my experience over my career, in my residency, basically it was outright warfare between orthopedic surgery, neurosurgery, and we didn't even know there were people who'd provided non-operative spine care because we were just too busy battling each other. My fellowship, we had a co-located spine center. So when I went to clinic, there was always a neurosurgeon and a PM&R person there, and if there was a more appropriate use of one of those other providers, we were able to hand it off right away. My first staff job I would call cooperating independent silos. So the classic old-time model of the neurosurgeon would do the decompression, the orthopedic surgeon would do the stabilization, and so we did cooperate and work together and we shared call. So what was wrong with all those systems? Well, first off, unnecessary delays in the referrals of non-operative patients. Waiting 9 months, which when I was in Canada was a short time, 9 months to see a surgeon, to be told you didn't need to see a surgeon, that doesn't make patients happy. But also, because I'm spending most of my time seeing patients who don't need surgery, I'm not seeing patients who do need surgery, so it's delayed access for the people who do need surgery. Patients hate being bounced around. They just want their problem treated. They don't care who's treating it, they just want to get better. So patients hated it. We hate it. Don't you hate going to clinic and seeing 10 new referrals and only getting one operative candidate out of that? That's a waste of your time. It also, I think, leads to unnecessary surgeries because, well, you've seen the patient, they've waited this long, well, let's do, maybe they would have been able to avoid surgery if they'd seen a different person first off. And again, the patients who need surgery aren't getting their surgery in a timely fashion when we're doing it this way. So, is there a better way? And I would say that perhaps there is. And what I'm going to tell you about is our model, what we have at the Cleveland Clinic. So we are a single clinical department. There are 4 orthopedic surgeons, 9 neurosurgeons, 14 physical medicine and rehab specialists, 3 pain psychologists, 2 neuroradiologists. We are all one group. My appointment at the Cleveland Clinic is not in the Department of Orthopedic Surgery, it is in spine. That's it. We share finances and we share liabilities, so if the program's making money, we're all happy. If the program's losing money, we're all in trouble. We do coordinated, co-located care. So anytime I am in clinic, there's a physical medicine rehab specialist with me. Half the time I'm in clinic, there's a neurosurgeon there at the same time. So if I have something I don't know what, and also, we have the ability through our shared electronic medical record and our shared PACS system to I can just call somebody and say, could you have a look at those films? So we are working together. We have a combined, our residents now work on the spine service. So at any given time, we have 3 neurosurgery residents, 2 orthopedic surgery residents on the spine service, and they are treated interchangeably. And our fellowship is 3 neurosurgery trained, 3 orthopedic surgery trained, and they all rotate through. So on any given day, I could be working with an orthopedic resident and a neurosurgery trained fellow, and vice versa. So how do we work this? Well, the way we work it and the way we've operationalized it, every new referral is screened by an advanced practice provider, so a nurse practitioner or a PA. Other models that are doing this, there's a couple of programs in Canada that are using physical therapists. So the patient is screened first, either physically by seeing them, or just on the referral, looking at the imaging, looking at the reports, deciding. If that patient is clearly surgical, they get an appointment with the most appropriate surgeon. So I do a lot of adult deformity surgery. It doesn't make a lot of sense for me to be seeing a lot of patients who need microdiscectomies. Somebody else may be more appropriate for that. If they're clearly non-surgical, don't have them see a surgeon. Have them see medical spine, pain, anesthesia, pain psychology if their problem is more a chronic pain syndrome. And then for those you don't know, if they need further workup, the nurse practitioner or PA sees those patients, orders the workup, does the workup, gets them to the point that they know is this surgical or isn't, and then send it out. And again, in every outpatient clinic, we are partnered with a physical medicine or rehab or non-operative spine specialist, and often we're partnered as well with the other surgical specialty. So, what are the results? Well, oh, sorry, let me go back to that. How do I go back? Okay, so we looked at this about 3 months ago. Of our new our new referrals that go to a surgeon, we as a group are operating on 80% of our new referrals. So that's working. We are seeing when we are in clinic, we are seeing patients who are surgical candidates. When I look at mine, I'm offering surgery to actually about 90% of the patients who get referred to me, about 10% refuse, about 80% go on to surgery. But also, of the non-surgery referrals, only about 25% of the patients that we identify as non-operative end up eventually coming to surgery. So we're doing a pretty good job of taking the non-operative patients, seeing non-operative specialists, and surgical specialists doing it. How have we made it work? Well, one is we actually get along. We have a very collegial atmosphere. We're friends as well as partners. We have a very unique financial and administrative setup at the Cleveland Clinic. We are all salaried employees on one-year contracts. No performance bonuses, so because of the way our finances work and the way it flows through, we can do that. We had administration buy into this very early on. We convinced administration that the expense of setting this program up was going to provide better care for patients, was going to give better patient satisfaction and better provider satisfaction. The real key is leadership, and to this I give credit to Ed Benzel, Gordon Bell, and Ian Kalfas, who are and were partners. They pioneered all this. They did the heavy lifting to get it all together. I just get to enjoy the benefits of it. It's a culture of cooperation. You have to be able to get along and compromise and things like that, and it takes time. I was actually hired at the Cleveland Clinic in 2003 by the orthopedic department. By the time I started, which was several months later, I was the first person hired on for spine. So I was there right from the beginning, and I would say it took us 8 to 10 years to get to the point where we had most of the bugs worked out. So why doesn't everyone do this? Well, again, we have this silo culture that we've been brought up with all of our lives. There is no doubt finances play a role, and if we didn't have the way our financial structure is set up, this probably wouldn't have happened. Personalities. You have to have people who are willing and want to cooperate and get along with each other. And again, because it takes time. And finally, there's a little bit of patient expectations. They've been told by their primary care doctor that they need to see a surgeon, and the first person they see is not a surgeon. That often gets people upset, but when you explain to them why, they usually come around fairly well. So if you don't have the way of setting that up, what are the other opportunities? The other opportunities working in a multi-care physician group, we have established care paths. We now all try to do all the investigation and surgical stuff consistently. It's great for research. We have a huge database of patient-reported outcomes collected across operative and non-operative disciplines. We're now using that data for predictive modeling. So we're using neural network artificial intelligence to look at a whole bunch of patient factors so we can decide what are the chances this specific patient is going to benefit from surgery And again, it allows cross-cultural training. How do you make it happen? Basically, and I'm going to pretty much stop here because now it's sort of like rah-rah stuff. This will be my last slide. But basically, how do you make it happen? You got to always put patients first. This is who we're here to treat. We have to do what is best for our patients. You need leaders committed to making it work. You need to get along. You got to play around with the financials. You've got to have a central clinic location, and you have to have consistent standards on care. And that, in a nutshell, is why I think we should all be looking towards a multidisciplinary program and what its advantages are. Thank you.
Thank you, Doc. A very important subject, and he enlightened us how to make a good spine clinic. Yeah, thank you. One thing that I'm always thinking that we are